Okay, so we are live. In order to have an interactive course, please state your name in the chat box. This way we can have a free discussion on the questions. Hello Lucas, pleased to see you again. We will begin shortly, so I urge any new participants to present themselves in the chat box to have the usual discussion on the questions. Okay, so let's start. Today we are talking about psychiatry and the cardiovascular system. Firstly, we have a 23-year-old patient that presents to the ED after he self-inflicted injury. He states that there are voices telling him he does not deserve to live. After a while, he becomes unresponsive to any stimuli, staring blankly at the ceiling. His friend states that his mood started to suffer 2 weeks ago. However, he heard the voices since they began college. What is the most probable diagnosis? MDD with psychotic features, schizoaffective disorder, bipolar personality disorder, or delusional disorder? Please state your choice in the chat box and then present a possible reasoning behind it. We have a B. Any newcomers? Do you have any other opinions? Please let me know your answer in the chat box. Observe that we are more today, so please let me know your name in the chat box so we can interact on these clinical vignettes. Hello, Carlos. Okay. Until we discuss the correct answer, let's see another clinical vignette. In this case, we have a 54-year-old woman that comes to the psychiatry unit to consult for reduced appetite, inability to focus, reduced sleep, lack of energy, and reduced productivity in her garden. Moreover, in the last 3 days, she hears voices telling her that she is unworthy of the life she has. What is the most probable diagnosis? MDD with psychotic features, schizoaffective disorder, C, bipolar personality disorder, or D, delusional disorder? Once again, let me know your answer in the chat box with a possible reasoning. I urge all the new students that participate to the course to state their name in the chat box so we can have a better interaction. Okay, so while for the first clinical vignette we had 2 B's and a D, everyone agrees on this clinical vignette that the answer is A. Let us see the answer behind both clinical vignettes. So the first answer for the first clinical vignette is schizoaffective disorder, namely B, while the second answer to the woman of 54-year-old, yes, is A, MDD with psychotic features. Let's have a review of what's the difference between these two entities. So, the schizoaffective disorder is a mood disorder plus schizophrenia. The important trait of schizoaffective disorder is the fact that we have at least 2 weeks of schizophrenia free from any mood disorder. By contrast, MDD with psychotic features manifests as a primary mood disorder that associates from time to time hallucinations or delusions. These hallucinations and delusions are mood congruent, so we have nihilism, guilt, as in the previous vignette, punishment, and other mood congruent delusions or hallucinations. What is important is the fact that the hallucinations or delusions occur only during the episode of major depressive disorder. Please let me know if you have any questions on this topic in the chat box. Do we have another student just joining us? If so, please let us know who you are so that we can discuss. Okay. The next topic is a cardiology topic. We have a 24-year-old woman with asthma that comes to the ED with palpitations after she initiated the treatment with salmeterol. On the ECG, the patient has narrow QRSs with a frequency of 170 beats per minute. In the lead 2, third, and AVF, there are negative P waves buried within the QRS complex. What is the most probable diagnosis? AVRT, atrioventricular nodal reentrant tachycardia, multifocal atrial tachycardia or MAT, or atrial flutter. Let me know your answer in the chat box. Okay, so the answer given by all of you is B, atrioventricular nodal reentrant tachycardia. Let's see the answer. As you can see, we are talking about atrioventricular nodal reentrant tachycardia. What are the reasons you chose B? Carlos tells us that the P is buried. Indeed, the buried P wave is a trait seen with nodal reentrant tachycardia, differentiating it from atrioventricular reentrant tachycardia. Okay. But there are also other traits that are part of AVNRT and that help differentiate it from AVRT. We will see further, but now let's see how we differentiate one from the other. So, AVNRT is usually paroxysmal. It is more common in women, as we saw previously, and it can occur after beta-2 agonists such as salmeterol. AVRT, so atrioventricular reentrant tachycardia, can be of two types, orthodromic and antidromic. The differential is important between the orthodromic AVRT and AVNRT. The cause of orthodromic AVRT is represented by functional AV node accessory pathway. This is extremely important because it is not a structural accessory pathway, such as in the antidromic. Before going further, do you have any suggestion of an antidromic AVRT with a structural accessory pathway? Please let me know the name of the structural accessory pathway as well as the name of the syndrome that is a antidromic AVRT in the chat box. Indeed, you are right. An antidromic AVRT is represented by Wolff-Parkinson-White syndrome, and the structural axillary pathway is the bundle of Kent. One aspect Dr. Deepak mentioned was the fact that it's treated with procainamide, yes, or lidocaine. Dofetilide is no longer used due to its side effect profile. Continuing, it is important to see what precedes the moment of AVNRT manifestation as well as the moment of AVRT manifestation on the ECG. Namely, AVNRT is preceded by a premature atrial complex, whereas an orthodromic AVRT is preceded by a premature ventricular complex. Although both of them have narrow QRSs, an important feature is the rate. Namely, for AVNRT we have a rate between 150 and 250, while for orthodromic AVRT there are higher rates, somewhere around 200 to 300 bits per minute. The P wave in AVNRT, as you mentioned in the chat, is buried within the QRS or shortly after it. It is always seen in D2, D3 and AVF. In comparison, in orthodromic AVRT, the P wave can be in more leads, especially including V1, and the RP intervals are longer. So we do not have a buried P, but also the P wave is at a distance from the QRS complex. Another feature that can help you identify an orthodromic AVRT on an EKG given on USMLE is an alternance QRS. Okay, please let me know any of your questions in the chat box now. What is the side effect profile? So the idea of the dofetilide is that it has proarrhythmic effects that are significant. So this is why it is not currently used. Indeed, Dr. Deepak, electrical alternance is seen in cardiac tamponade. But there is a difference, namely when we talk about electrical alternance, we talk about changes not only in the QRS, it's reversely. So with QRS alternance, there is modification of both width and amplitude. Whereas in the case of electrical alternance, we have only amplitude variation. Okay, let's pursue further and take a break. If you like this content, please like the video and subscribe. If you are subscribed, you will be notified on more content for USMLE. If you want to support the channel growth, you can do so by becoming a patron. I will leave the link in the chat box, although I do not expect to work. But let me know if you'd like to. We have newcomers, so I'm glad to say hello to you and to welcome you. Leave your name in the chat box so we can interact in the second part of the course, as we will start actually in 1 minute maximum to discuss the second part of the course on psychiatry and cardiology. Okay, so probably we have watchers and not players. Let's pursue further with the next clinical vignette. A 53-year-old patient develops ventricular tachycardia after 2 days in hospital for myocardial infarction. The patient is 120/80. However, there is no radial pulse palpated. What is the best next step? Synchronized cardioversion, amiodarone, procainamide, or defibrillation? Let me know your answer in the chat box. Okay, we've got 3Ds. Let's go to the next clinical vignette and then we'll sum up everything nicely. A 26-year-old comes to the ED complaining of palpitations. He stayed up all night to prepare for his upcoming exam. He drank at least 6 Monsters. He's sweaty and he speaks rapidly. On the EKG, there is a normal sinus rhythm with 150 beats per minute. The physician massages his carotid sinus with no avail. The pulse is maintained at 160. What is the best next step? Bisoprolol, adenosine, amiodarone, or diltiazem? Let me know your answer in the chat box. I'm notifying you that I'm expecting 5 answers from the number of people that watch currently. Even though Carlos, Lucas and Dr. Deepak are highly active, and I'm very glad that you are active. I hope that the other students will join the conversation. Okay, indeed, Dr. Deepak is right. This is an SVT that is usually treated with adenosine in case of failure of Valsalva or carotid sinus massage. Let's go through the first clinical vignette first, where the correct answer is D, defibrillation. And the second one is B, adenosine. So how do we treat ventricular tachycardia for the algorithm? Now, we have to practically separate the population with ventricular tachycardia into hemodynamically stable and hemodynamically unstable. Hemodynamically stable means that the pulse is felt and that they are normotensive or hypotensive. If the patient has pulse and he is normotensive, then we administer amiodarone or lidocaine or procainamide. However, if the patient is hypotensive, then we pursue with synchronized cardioversion. Our patient, although was normotensive, he was without pulse, making him hemodynamically unstable. To have a patient that is hemodynamically unstable, we need no pulse and hypertension. Hypertension. In this case, we pursue with unsynchronized cardioversion, namely defibrillation. Now that we saw how the algorithm for ventricular tachycardia works, let's go on how to treat the SVT that Dr. Deepak identified previously. In case of sinus tachycardia, the pulse is greater than 100 beats per minute, and the important trait that differentiates it from other supraventricular tachycardias is the fact that there is a sinus rhythm. The management is pretty simple. We either do a Valsalva maneuver or carotid artery massage, or we consider adenosine if this fails. However, per new recommendations, if the patient had myocardial infarction prior to the episode, then we will consider the first line therapy of beta blockers. We skip Valsalva, we skip carotid massage, we skip adenosine, we go straight to the beta blocker. Otherwise, if the patient had myocardial infarction before the sinus tachycardia episode, but the beta blockers failed, we use the last resort antiarrhythmic, namely calcium channel blockers. More precisely, non-DHP calcium channel blockers. Do you have any questions on these two algorithms, as they will be on USMLEs, especially if they give you an ECG? Carlos, yes, indeed, I was also surprised. I had one question that worked exactly like this. Synchronized cardioversion is indicated if the pulse is there. So if the patient is hemodynamically unstable and he has pulse, we cannot go into unsynchronized defibrillation because we will actually induce a cardiac arrest. So this is why we practically treat hemodynamically stable but with pulse patient as a patient with atrial fibrillation. So we need to synchronize that electrical impulse with the QRSs. This is why we have to do a synchronized one. Was it clear, or would you like me to rephrase it to understand better? It's my pleasure, Carlos. Okay, let's switch back to psychiatry. A patient is hospitalized in the psychiatric unit due to 3 months of inappropriate behavior after starting college. His roommate stated that during these months he was withdrawn in his room. Lately, he maintains the curtains closed at all times due to being surveilled by the FBI satellites. Also, the colleague saw him 2 days ago curling in the corner of the room, shouting to some imaginary friend, "Leave me alone!" What is the most probable diagnosis? Schizophrenia, brief psychotic disorder, schizophreniform disorder, or schizoaffective disorder? Let me know your answer in the chat box. We have a C. What are the opinions of the other viewers? Okay, let's do the second. No, sorry. So the answer indeed is C. Let's talk about the timeline for schizophrenia spectrum disorders. So a brief psychotic disorder is presenting with the same symptoms as schizophrenia, namely negative symptoms, delusions, disorganized thought or speech, and hallucinations. Always remember that you need to have at least one of the last three traits. But in the case of brief psychotic disorder, it manifests between 0 days and 1 month. To diagnose a schizophreniform disorder, we need the same schizophrenia symptoms, but with a duration between 1 month and 6 months. Lastly, schizophrenia is diagnosed from 6 months on. Okay. Now, let's see some questions that you can have on schizophrenia. Firstly, what is a poor prognosis factor for schizophrenia? Indeed, Carlos and Dr. Deepak have a point, namely the poor prognosis factor that is usually asked on USMLEs is age. Namely, the younger the patient is, the poorer the prognosis. Okay. Now, is the genetic component for schizophrenia a Mendelian one, or it is, what's the other question? It is determined by multiple genes. Indeed, schizophrenia is a polygenic disease. It is like heart disease or diabetes or obesity. One other trait for schizophrenia is the fact that it has, even though it has family aggregation, namely a family history is an important risk factor, it is not so prominent as the twin studies showed that only, if I remember well, 25% of the siblings will develop schizophrenia. However, the percentage might not be accurate. Yep, marijuana increases the risk of schizophrenia. I will come up with a note to the previously stated affirmation of the risk. So if we have fraternal twins, the risk was of 70%. If we had identical twins, the risk was somewhere around 48%. Okay, so now we are at the end of the course. Please leave topics in the comments after this video ends. Leave any topics you might consider that might help you. Also share the YouTube channel to other students so they can engage with these courses live, or if they want to just watch them without participation and they have no questions, then they can just see them as they upload themselves. Now, if you want to delve deeper in medical content related to USMLE, you can check the playlist that I will leave in the chat box. I am grateful for your presence and for your involvement in the chat. And I'm looking forward to the next live stream, which will be streamed next Saturday at around the same hour, and hopefully all of you will participate in the discussion. Do you have any questions regarding this course, any suggestions? Please let me know about them now in the chat box before ending the course. There is a mention, if you want to get the weekly newsletter that comprises summary sheets of different topics that we discuss either here or that are discussed in the videos, please email me at medicalperspectiveblog@gmail.com. Okay. And you will receive the newsletter. Okay, if everyone's happy, then I wish you good luck and see you next time. Bye.